We're going to start with mood disorders, with a particular focus on the treatment, like I just said. And if you want more on pathophysiology, that's on Monday. So the first question is, which of these is an SSRI? So I hope you can see that on your screen. If you can't, shout, but people are answering, so I'm hopeful. So it's amitriptyline, fluoxetine, phenelzine, or venlafaxine. We've got 6 answers so far. If anybody else wants to answer, do so now. Okay, so I'll show you the answers. So the answer is fluoxetine, and 100% of you got that right. So that's a pretty promising start. Well done, guys. Super proud of you. And then our next question is, in the serotonin hypothesis, A, there is too much serotonin at the receptor. B, there is too little serotonin at the receptor. And C, there is no serotonin at the receptor. So this is a serotonin hypothesis of why you get depression. We've got lots of answers there, so let's show you the results. So all of you got that right as well. It's very promising. Well done, guys. Super impressed with you. And last one for this section. So benzodiazepines, such as diazepam, are used to treat anxiety sometimes. Which of these are one of the concerning side effects? So I'm going for the one that's kind of in your syllabus that you really need to know about. Okay, I'll give you a couple more seconds to answer. Well done, everyone. And so those are the results. So although you can potentially get some of these other side effects, the main one that we need to worry about is addiction, because benzodiazepines are really addictive, and they want you to know about that. So benzodiazepines are going to come out later when we talk about recreational drugs as well, because they're also a drug of abuse and they are highly addictive and then have quite bad overdose symptoms as well. So it's quite important. So we'll come back to some Socrative later, but now we'll start talking about the things. So these are the classifications of mood disorders that they want you to know about broadly. So you've got your unipolar disorders and your bipolar disorders. So we'll start by talking about bipolar disorders. So that's obviously bipolar disorder is the swinging between episodes of mania and episodes of depression. They usually last for a couple of days, maybe a couple of weeks each, and then they will rapidly swing from one to the other. Mania can actually also be as disruptive as the depression, because people take risks that they would not normally take. It's often associated with things like gambling and can be very, very disruptive to people's lives. And then cyclothymic disorder, which I put on there as well, is another example of a bipolar disorder. It's kind of just a more minor version. So they still get these mood swings, but they're usually less severe than what you'd experience in bipolar disorder. The extremes kind of less extreme. Then in unipolar disorders, I've split that into anxiety disorders and depressive disorders. So in anxiety disorders, we have phobias, which is the fear of a specific thing, panic disorder, which is panic attacks, which occur intermittently with no particular cause, and then generalized anxiety disorder, which is kind of what you consider like your typical anxiety and what you imagine when you think of as anxiety disorder. Then you've got depressive disorders. So here I put major depression, which again is like your typical depression, is kind of that low mood that's persistent, associated with either weight gain or weight loss and sleeping disorders, but we'll cover more of that on Monday. And then seasonal affective disorder, which is kind of when you get depression, but only really in winter, and it kind of changes with the seasons and occurs every single year. So then we're going to talk about the serotonin hypothesis, which kind of came up on our questions earlier. Seems like you guys kind of know a bit about this already. So it's about a serotonin imbalance causing depressive symptoms, and it involves the deficiency of serotonin at the synapse. And the idea is that the serotonin is kind of, because it's not there, is causing a low mood. The serotonin hypothesis is also called the monoamine hypothesis in your syllabus, but I think it's more commonly known as the serotonin hypothesis. I put that in. So the arguments for this is because the selective serotonin reuptake inhibitors, or SSRIs, are really effective treatments for depression. And so the idea is that by adding more serotonin at the synapse, that reverses the disorder, and therefore there must be too low serotonin there initially, and that's why this fixes it. And also because there are some experiments where they're able to reduce the serotonin level at the synapse, and that will induce depressive-like symptoms. So they said that that's evidence for the serotonin hypothesis. However, against this is that antidepressants might actually be modulating a distinct process, but still solving depression. So the example that often I was given when I did my degree was about that when we treat pain with paracetamol, we're not saying that somebody has a paracetamol deficiency and that's why the paracetamol works. So why would we say the same thing for antidepressants? Because just because you're adding more serotonin doesn't mean that there was a serotonin deficiency automatically, right? And also the fact that SSRIs aren't specific to depression. So the fact that you can use them in anxiety and lots of other psychiatric disorders suggests that it can't be the serotonin hypothesis alone that is causing the depression, right? So this is a bit of a daunting slide, but I thought I'd put it in because it's really helpful when we consider the drugs. So you definitely do not need to learn this, but I thought that, so if we look here, you've got your monoamine oxidase halfway down the serotonin, and that you can see is turning the serotonin into other products, right? And so we know that this monoamine oxidase inhibitors therefore stop that, and that's why you get more serotonin. And then on the picture of the synapse, we're mostly focusing on the presynaptic neuron, and you can see all these transporters. So you've got your 5-HT transporter, your NA, which is noradrenaline transporter, and your DA, dopamine transporter. And those are what are affected by most of these drugs to stop the reuptake. So I think it's helpful to just picture in your mind what it is that these drugs are doing and therefore why they work in increasing your serotonin. So we've got our antidepressant drugs. These are all of the ones in your syllabus that I think are like the key ones. So we're just going to work through them one at a time to kind of get an idea of how they work. So you've got your tricyclic antidepressants, or TCAs, as they're referred to in the later slides. So it's amitriptyline is your main one. These are kind of the original antidepressants. They were found accidentally when they were trying to treat used as antipsychotics, which they don't actually work for, but now they're used as antidepressants. They block the uptake of amines in the nerve terminal, and they act more on the serotonin and noradrenaline receptors, but they also work a little bit on the dopamine receptors, hence the transporters, hence the tricyclic, because it works on all three. So then they also have side effects. The most important of these side effects, which I've kind of put in mostly for interest, but the ones in bold are always the ones that you need to know. So you've got ventricular dysrhythmia, which obviously is quite bad because it can cause like permanent heart damage and also death. So that's not ideal. And obviously having an antidepressive drug that has an overdose potential is really dangerous, because obviously you always have that risk of suicide, especially in the initial treatment phase. So that makes this really not an ideal drug as an antidepressant, the fact that you could overdose on it. So I'm going to talk about selective serotonin reuptake inhibitors, which you guys all told me was fluoxetine. I also put in sertraline and citalopram because they're quite common drugs that are taken, so I thought they're quite important to know as well. And they prevent the reuptake of serotonin in the presynaptic cleft, which means that there is more serotonin available for the postsynaptic cleft, so it's more excitable. Then there are less side effects for this than the TCAs, but it's really important that in children it can cause some suicidal thoughts, so it's not ideal for treatment of depression in younger people. It can only really be used in people over 18 for that reason. And then selective noradrenaline reuptake inhibitors like phenelzine, they function similarly to SSRIs, but they function on the noradrenaline reuptake instead. And then they also have some side effects like headaches, insomnia, sexual dysfunction, dry mouth, dizziness, and you can also overdose on these, which causes seizures and cardiac arrhythmias. And then MAO inhibitors, so that's a monoamine oxidase inhibitor, like venlafaxine. These cause a sustained increase in serotonin, noradrenaline, and dopamine by inhibiting the monoamine oxidase enzyme that we were talking about earlier. So we've also got some side effects here, but something you should be really aware of is that monoamine oxidase inhibitors cannot be prescribed with these other medications, especially TCAs and SSRIs, because that will cause a thing called serotonin syndrome, which is when you have it create symptoms such as hypothermia, muscle rigidity, and cardiovascular collapse, which is obviously very serious because the idea is that you've then created so much serotonin that it's toxic. Because you've blocked the breakdown of it and you've blocked the reuptake of it. And so now none of the serotonin is being removed from the cleft, and that can be a very, very serious side effect of mixing these drugs. So it's important to know. Just going to go to the next slide. Did that just change slides for you? I hope so. Shout if not. So I just thought I'd go back to that original image. So what we've got here, I've circled in the colours that I've written them in the key, which transporter or enzyme is being affected by the drugs, to give you an idea of it. I think it would just help to like picture it, and then you can remember them better, I think. So if it's circled in a dotted line, it means it has a partial action. So it's not going to completely block it. It's just like slightly affecting it. Like you can see with the SNRIs on the serotonin inhibitor. And it's also important to note that just because it's meant to focus on one of these transporters does not mean it's specific, like you can see there. So yeah, it's more just for your revision, this slide. Then you need to have some evidence. So I found a Cochrane review that you can use, because obviously Cochrane reviews are kind of the highest level of evidence. So you can use to show that antidepressants really do work. So this slide is showing the effects of TCAs on depression, and because on this forest plot at the bottom you can see that diamond and it's not crossing the line, that means that it is an effect, and so therefore we can say that TCAs are an effective medication. But like we discussed, the adverse effects of using TCAs kind of put people off using them very often. Then you've got this one, which is SSRIs. In the slides when you get them, there's notes underneath, and the notes will tell you which ones apply to which, so don't worry, if you want the slides and you come back to them, you will know. So this shows the difference in the use of SSRIs, and here again you can see that the diamond doesn't cross the line, and therefore when you compile all of the literature in the primary care setting on the use of SSRIs, they do work to reduce antidepressant depression symptoms. So that means that they're effective treatments for depression. So now we're going to move on to the anxiolytic drugs. So barbiturates were the original anxiolytic drug, but they're not really used anymore. They're kind of an old treatment for anxiety. An example is phenobarbital, and they work on GABA A receptors as an agonist. Their main side effects are overdose, addiction, sedation, that you become very tolerant to them quickly, which means that you're going to need high doses the longer that you're on them. They also cause megaloblastic anemia and osteomalacia, which are not ideal side effects. They're really rarely used, and they're actually much more of an anti-epileptic drug now, and they're also used in anesthesia. Then you've got benzodiazepines, like we were discussing earlier, such as diazepam, lorazepam, midazolam. They come up quite a lot in our medical practice, but again, not so much as treatments for anxiety usually, but they do work like that. But they have severe echo. Everyone muted. Thanks, guys. Okay, good. So we've got the main side effects of this are withdrawal and addiction, and plus there's a lot of potential for overdose. And tolerance, again, with confusion, amnesia, impaired coordination, and also anybody that's on this who drinks has a severe reaction. So that's obviously not good for long-term treatments if you're worried that somebody might be abusing alcohol or even just drinking socially. It's quite dangerous. So then you've also got buspirone, which is a serotonin receptor agonist, which has much less side effects. So I believe that it's also better to use because it's got a lower threat of abuse. And then you've got beta blockers, which we know can also be used for things like hypertension. They usually use propranolol, which is a general beta antagonist, and it works to just reduce overall sympathetic nervous system responses. The main side effect you need to know about that is bronchospasm, because that means it cannot be given to people who are asthmatic. Then other mood disorder medications which are on your syllabus are lithium, which is used for bipolar disorder, but they're not really clear how that works. They think it might make the sodium channels more excitable. It's really important that it's nephrotoxic because it can cause lots of kidney dysfunction, so you need to know about that. But again, they just don't really know how it works, so there's less to say about it. Then you've got these other medications which aren't really used that much in practice. And as you can see, they all kind of function on a mix of sympathetic nervous system receptors and serotonin receptors and a little bit of histamine. They also have quite a large side effect profile, but these are kind of the main ones that I put in for you. But I think they're quite small print, so I don't really want to go over them too much. And then you've got agomelatine, which works as a melatonin agonist, which is a little bit different against depression. But again, very small print kind of medications, but they are on your syllabus, so I thought we'd bring them up. Then in terms of alternative therapies, we've got ECT, which is electroconvulsive therapy, which is done for people where other treatments have failed. ECT in general has a really bad rap as being really unethical, and it was abused in the past and used completely inappropriately, but now it is an effective treatment to treat major depression where nothing else has worked, but it's much more humane than it used to be. So the patient is anaesthetized and paralyzed during the treatment, so you don't get any of those like convulsions during it. So that's not really what happens anymore. They don't really know how it works. It's one of those where they think it decreases beta adrenoreceptor responses, but they don't really know. And the side effects during it can be like afterwards when they wake up, the confusion and memory loss, but those tend to be regained afterwards. It's generally perceived quite poorly by the public, but it can be really effective and life-changing for the patients that do have it. They can also use TMS, which is transcranial magnetic stimulation, which works similarly to ECT, but is using magnets instead. So it's safer, you're not going to get that risk of convulsions, and you don't need to be anaesthetized. And since these tend to be long courses of ECT, and having regular anesthetic is probably not great for you, so TMS might be a better alternative. Then we also have obviously CBT, which is cognitive behavioural therapy, but we're going to talk more about that on Monday. So now we're going to talk about schizophrenia. So again, we've got a couple of questions. So the first question is, I just wanted you guys to name some positive symptoms of schizophrenia, if you can. Since you're not seeing it, I'll read out when I get anything. And obviously it's all anonymous, so don't be too shy. And I think if you've accidentally left, your things will be in there. So we've got hallucinations and delusions. Yeah, more hallucinations. Thanks, guys. Yeah, hallucinations, delusions. Well done, guys. That's it. Good. Fab. So, then question 5. I will move on to question 5 for you. Is which of the following are side effects for typical antipsychotics? So these are the first ones, the original ones that came out, and you may pick more than one, and I've said that because you should pick more than one. Okay, I'll wait for a few more of you to respond. Good, that's lots of results. Thank you, guys. So there's a bit of mixed answers from you here. So lots of you got that tardive dyskinesia is one of the side effects of typical antipsychotics. Quite a few of you said weight gain, but weight gain is the main side effect of atypical antipsychotics, and that's kind of an important differentiation for you to make. So those are the more modern ones, the newer ones, which don't cause tardive dyskinesia, but do cause weight gain. And it can be quite significant weight gain in atypical antipsychotic use. And then gynecomastia, which is the development of breasts in males, is actually one of them. It's quite a common side effect of using antipsychotics. And seizures is not actually one for this, but is again one for the atypicals, but very rare side effect. So we're going to move on to what is schizophrenia. So as you clearly mostly know, positive symptoms are things that are added on to someone's personality. So that includes delusions, hallucinations, and impaired reality orientation. So they're not aware that what they're experiencing isn't real, and that's quite an important part of it. So the delusions include things like delusions of grandeur, believing that you are Jesus and things like that, or it can be kind of very paranoid delusions where they believe that somebody's after them, that they're being watched and things like that. Hallucinations are often auditory, but they can kind of be anything. Lots of people experience visual hallucinations, or even hallucinations with taste, things like that, or sensation where they feel like something's crawling on them. But auditory is the most common. Then your negative symptoms are things that have been taken away from your personality. So that's things like apathy, which is like and flat affect, so like a low mood, or just not really feeling very much. And they have very passive faces where they don't really give away much by way of facial expressions and things like that, and a poverty of thought. So things just kind of go a bit more blank for them. It's also often associated with quite depressive symptoms as well. So who gets schizophrenia? So everybody has a 0.8% lifetime risk of getting schizophrenia. It can occur anytime between 7 and 70, but typically occurs in the 20s or late teen years. It's actually an equal sex ratio if you have a broad definition of what schizophrenia is, but men tend to get it earlier presentations and more severe presentations than women. The cause is variable, where around 20% of people will recover from the schizophrenia, 40% will remit but relapse, and 20% have chronic symptoms and impairments, which is obviously quite a large amount given that it's quite a debilitating condition. You get increased mortality as there's a 3 times increased chance of suicide, with 10% of people with schizophrenia dying by suicide. And life expectancy is reduced by a total of 15 years. Comorbidities are common, such as substance abuse, which we'll come on to later. Risk factors for schizophrenia are birth complications, urbanicity, migration, maternal infection during pregnancy, having an older father, childhood abuse, and early cannabis use. But lots of these risk factors are associated with schizophrenia, but it's unclear whether some of them is if you are schizophrenic, you're more likely to live in a city, or whether living in the city has caused your schizophrenia. But interestingly, the larger the city you live in, the more likely you are to be schizophrenic. The birth complications, well, this is written in order of association. So birth complications is the most associated with schizophrenia, while early cannabis use is the least associated. And yeah, it's a bit difficult to tell with these things whether they have actually caused it, but they are definitely associated with schizophrenia. Then you've got the genetics. So there is definitely some genetic association between with schizophrenia. Lots of genome-wide association studies have been done, which have shown that there's a link with chromosome 6, but multiple different genes, and there's no one gene that's going to cause schizophrenia. It's going to be a multitude of genes that kind of come together, plus life events that then lead you to become schizophrenic. But as you can see, in identical twins, that's a 48% concordance rate, which is quite high. So it does suggest a relatively strong genetic link, especially for a psychiatric disorder. And then if you're looking, then that risk goes down with how related you are. So your 1% risk is the general public, but 48% if your identical twin also had schizophrenia. And then if it was just another sibling, it'd be 9%. Yeah. So the psychological theories of schizophrenia are a little bit dubious, especially the older ones and the psychodynamic ones, which suggest that like schizophrenogenic mothers and the way that your mother treated you would cause you to have schizophrenia. But those have basically been discarded now, and we can kind of ignore them. The current models are mostly about cognitive neuroscience. So the idea that delusions are created because of the failure to integrate sensory perceptions of the internal world, or failure to distinguish between two concepts, or also attentional problems from cognitive impairments and prefrontal dysfunction. So you've got the dopamine hypothesis in schizophrenia, which suggests that there is too much dopamine present in schizophrenic people. Positive psychotic symptoms of schizophrenia are due to dopamine excess in the striatum, and then the negative symptoms are due to too little dopamine in the cortex. There also might be a difference between glutamate, which is a target for new drugs. This graph that I've got on the side here shows that with increased dopamine present, they respond better to treatment. So that's what that association is. where the more dopamine present, the more likely you are to respond to antipsychotic drugs affecting dopamine. So the neuroanatomy. So there's lots of fMRI and PET studies done on people with schizophrenia, which look at the glucose metabolism and cerebral blood flow. So cerebral blood flow is obviously fMRI, and glucose metabolism is PET scans. Overall, there's hypofrontality, so there's not enough activation in the frontal lobes, but it depends on the phase of illness that someone's in. So this changes as they're having a particularly bad time. They'll have more hypofrontality, and when they're actually living life relatively regularly, they will have normal activation or near normal. From other fMRI features, depending on the symptoms, so when somebody is having auditory hallucinations, you can see that in the temporal lobes, which I'm sure you will know is the auditory area of the brain. So you can see that light up as somebody has a hallucination, so it is like they're actually hearing it. And then there's increased hippocampal activation during delusions. And as you know, the hippocampus is involved in memory and the integration of memory. So there's also altered resting state networks, and people who are relatives of people who are schizophrenic and therefore at more risk of being schizophrenic themselves also have some differences on fMRI as well. So we're going to look at the antipsychotic drugs. So as we were discussing earlier, you have your typical antipsychotics, which are the old ones, and your atypical antipsychotics, which are your new ones. So haloperidol is a typical antipsychotic. It affects the D2 receptor by blocking it. One of the main side effects of this is tardive dyskinesia, which you can see in the picture here. And then also gynecomastia, which is the development of breasts in men, as we were discussing, and hypothermia. Tardive dyskinesia is one of those things that comes on gradually. So initially, they're probably not going to get it, but the longer that they're on the antipsychotic for, the more likely they are to get it. And it's an uncontrolled movement of the face, kind of resembling what you might see in Huntington's or something like that. Then in atypical antipsychotics like clozapine, you get also D2 receptor antagonists with more of an autonomic nervous system effect. This also has much better at treating both positive and the negative symptoms, whereas your typical antipsychotics are much better at focusing on the positive symptoms and not the negative symptoms. So even though they're not hallucinating anymore, they still have that apathy and that generally low mood, which is obviously not really solving the schizophrenia problem overall. So these are considered much better. They're in much more general use. Their side effects tend to be like sedation, weight gain, salivation, agranulocytosis, hypertension, and seizures as a very rare side effect, but they are generally safer. People generally prefer them. But as I said earlier, the weight gain that people experience taking atypical antipsychotics can be really significant weight gain. And obviously people are on these drugs for years and years. So as you can imagine, that means that obesity is very prevalent within the people that use these drugs and can also be partly responsible for shortening lifespan. Then you've got chlorpromazine, which is a type of drug called a phenothiazine. It affects the D2 receptors like the others, and it's also an alpha-1 blocker. Then it also has very similar side effects to the typical antipsychotics, with tardive dyskinesia, sedation, hypertension, gynecomastia, hypothermia, and obstructive jaundice. So those are the main ones that you need to know about. So that's great. We're going to move on to drug addiction and recreational drugs now. So we've got some more Socrative questions. So firstly, a key brain area involved in the dopamine pathway of addiction is A, the parietal lobe, B, Raphe nucleus, C, nucleus accumbens, or D, cerebellum. So focus on the dopamine pathway here for this. Just give you a couple more seconds to respond if you want. Fab. Great, I'll show you the results now. Okay, so most of you got that it's the nucleus accumbens that affects the dopamine pathway. So that is part of the whole basal ganglia circuit that you have, and that is also involved in addiction. So the Raphe nucleus, which none of you selected, well done, is involved in the serotonin pathway of addiction, so it's quite important for that. And then the cerebellum and the parietal lobe are much less involved in addiction. So 4 features of addiction. So we can break it down into dependence, tolerance, withdrawal, and cravings. I'm sure you all have vague ideas of what these mean, but we'll just go through it anyway. So your dependence is the compulsive drug taking, which overtakes other needs. The dependence can be both physical and psychological, because as we'll see later, a lot of people who are addicted to alcohol and opiates have very physical requirements for those drugs after they become addicted. Whereas psychological effects are also equally play a role in that dependence and that need to take the drug next. So tolerance, as has kind of come up in the past of this lecture, which is the decreased pharmacological effects. So that's when you are taking a drug and each time you need to take a little bit more because you become more tolerant to the effects of that drug. So each time you take it, the same amount will do less and less and less. It's something that does occur in drugs like opiates, but it doesn't really occur in all of the drugs that we'll discuss today. Then withdrawal is the cessation of drug resulting in physiological effects. So that's those very, which is seen a lot in alcohol and opiates again. It's a very physical response to withholding drugs from people, and it actually can be life-threatening in some cases. Then cravings are after somebody has stopped taking the drug or it's been a while since they had their last dose, is the longing to experience that again, and it can be as a result of the psychological dependence, and is the most common cause of relapse. So we're going to talk about the neurobiology of addiction. So most addictive drugs stimulate the release of dopamine from the mesolimbic system, which results in dysregulation of mesolimbic and affective basal ganglia circuits. The effectiveness with which dopamine transmission occurs is initially compromised, resulting in tolerance. And then once addiction is established, the mesolimbic system becomes sensitized to drugs. The same circuitry that you see here is involved in both gambling addiction as well and food addictions, which cause obesity. So as you can see, it's kind of a mix of dopamine and serotonin pathways that are involved. And it's due to the reward, the pleasure. It also changes your motor functions, has compulsion, and that's why the dopamine is so prevalent, because obviously that compulsive nature is affected by the dopamine pathway. And then serotonin pathway is more involved in your mood and your memory processing. So you're altering your memory process when you're taking the drugs, which can be a reason for addiction. And then it also changes your cognitive abilities and your sleep. So I'm going to talk about the molecular mechanisms of some of our key points of drug addiction. So dependence occurs due to the activation of reward pathways, which enhances your dopaminergic neuron firing, and it disinhibits your GABAergic neurons. And your GABAergic neurons are usually inhibitory neurons. So by disinhibiting them, you're increasing the overall action, if that makes sense. Then tolerance. So you've got long-term potentiations in the VTA, which is the ventrotegmental area, by increasing the expression of AMPA receptors. So that's affecting the long-term effectiveness of these areas. So the long-term potentiation means it's overall suppressed by the effect of the drugs. So next time you need more of it to overcome that, right? Then withdrawal is the increased expression of cyclic AMP, and it involves binding proteins in response to activation of D1 receptors, which result in increase of PKA, which is protein kinase A, making nerves more excitable and more GABA is released. So this is a little diagram I took from a textbook I'm going to tell you about later, which I really like. So it kind of goes through the learning that can be involved in drug taking and how you end up with reinforcement learning and that kind of idea of operant conditioning, where you associate a reward with a cue and that makes you learn to repeat the behavior, right? So here you've got cues associated with drug taking, such as a social situation in which you might take drugs, the purchasing of drugs, or the preparation of drugs, which then obviously leads to drug administration. And then this is reinforced by the reward you get. So you learn to take the drug to get that reward. And the reward will be immediate, brief, and it decreases with repetition in some cases, as we discussed. And then overall, this pattern of going from cues to reward leads to positive conditioning, where you associate that cue with the reward. So that might be a social situation, which could be very damaging. So you being at a party and over consuming alcohol and binge drinking, you associate that with the reward of feeling drunk, right? So then you, in the next time you're at a party, you remember that reward and you therefore take the drug again. And then you also, counter to this, have negative conditioning towards withdrawal. So you get your cues associated with drug withdrawal, such as the hangover feeling in the morning, right? And the non-availability of that drug for the case of things like opiates, where you're not able to get hold of it anymore. Then you get drug withdrawal, which negatively reinforces abstinence, so that you no longer want to be abstinent because it's making you feel this way, and you get the association of the social situation to the abstinence. So the abstinence usually is delayed, long-lasting, and increases with repetition. So you get negative conditioning from the cues that are associated with your withdrawal, like the non-availability of drugs, and abstinence. So you try and avoid those situations because they are associated with bad feelings. So we're going to go through some of the recreational drugs in your syllabus. I figured we'd focus mostly on the mechanism of action. We kind of briefly go through the positive experiences that people have, which explains why they might take them. And then there are a few of the adverse effects, because the adverse effects can be really important for us to understand in order to know what to look for in somebody who is dependent on drugs, and because they'll be helpful in your future clinical practice, and also help you understand what it is that we need to control when we're helping somebody come off drugs. So we'll start with opiates, which such as morphine, heroin, and oxycodone. Obviously, some of these are drugs that we do use in clinical practice regularly, and they are very addictive. They have analgesic effects, hence why we use them. And they act on the opioid receptors, otherwise known as mu receptors. The adverse effects are things like constipation, which we get in most of the opiates we use in clinical practice, like codeine. And then they also cause that overdose effect by respiratory depression and coma. They're also incredibly addictive, so they cause dependence. And as we discussed, they cause overdose by respiratory depression, and they can cause vomiting. Then we've got nicotine, which is obviously in cigarettes. It affects your nicotinic acetylcholine receptors. It increases the neuronal excitability, increases mesolimbic pathways, which is that reward pathway we were talking about. It's very addictive. It causes tachycardia. It's teratogenic, which means it will affect a fetus if you're pregnant. In this case, it makes you have a particularly small fetus and can affect neuronal development. And also you get the adverse effects of smoking, which I'm sure you know about, like COPD, lung cancer, that kind of thing, obviously. Then we get, so then you've got your cannabinoids, so that's marijuana, smoking cannabis. The effects are usually euphoria and relaxation due to the action on cannabinoid receptors, which have psychomimetic and depressant functions. Then you get your adverse effects are long-term psychological effects, catalepsy, hypothermia, and increased appetite, and obviously the effects of smoking again. But these are actually much less addictive than some of the other drugs that we've discussed, which is worth knowing about, because compared to nicotine, it's much, much less addictive. Then you've got your benzodiazepines, which we discussed earlier, so I won't go through that too much again, but mainly it's on here because of the withdrawal and addiction effects, because it is very, very addictive, and people use it as a drug of abuse for its kind of, its feeling of, it's a bit of a depressant, that's what I was looking for, in the way that it works on people's overall moods. It's often used as a drug of abuse to mix with things like MDMA or cocaine as like a downer afterwards. Then, which also has adverse effects because mixing drugs is an under-researched area, but very important because they have different adverse effects when they're mixed with each other. So then you've got psychotomimetics, which is things like LSD and mescaline. So it's anything that really causes a hallucination, and that's caused by an agonist effect on the serotonin 2 receptors. Interestingly, psychotomimetics are the only drug on your list of recreational drugs that animals will not choose to take. And the effects can last up to 6 weeks after you take them. And here you need to note that schizophrenic people who take psychopharmacology are particularly prone to having adverse effects from them. They're often, the adverse effects can be paranoid delusions, persistent psychiatric disorders, and flashbacks. And those flashbacks can kind of continue up to the 6-week period after taking them. Then your recreational drugs, more recreational drugs. We've got amphetamines, which are used to treat ADHD in a clinical setting, that can be used as drugs of abuse. It includes things like speed. It gives excess energy by the release of an inhibited reuptake of catecholamines, so dopamine. Then it causes dependency, sympathomimetic effects, so effects of sympathetic nervous system, pulmonary hypertension, anorexia, paranoia. And then amphetamine psychosis, which presents like a schizophrenic attack, but is caused by an overdose of amphetamines. Then you've got cocaine, which creates a sense of euphoria by the inhibition of dopamine and noradrenaline reuptake, and it increases sympathetic activity. Then you've got tremor and convulsions as the main adverse effects. You can overdose on it, and it's very teratogenic, which means if you're pregnant and you take cocaine, the baby can be very adversely affected by that. It also causes things like heart attacks, strokes, cardiac arrhythmias, all sorts of things that are worth knowing about if somebody presents to you in A&E one day. Then we've got alcohol, or ethanol, as the medical term for it would be, which causes a general CNS depression by enhancing GABA, glycine, and inhibiting calcium channels. Although it has many different effects, and they're not really sure of which are the main effects involved in addiction and things like that, but it does affect a lot of your general neurology. The effects of alcohol include fetal alcohol syndrome, which can be absolutely horrendous, neurological degeneration, peripheral neuropathy, and then obviously the liver effects. And then it's really important here to know about the withdrawal effects of alcohol, because they can be life-threatening. So people can experience delirium tremens, which is when you get fevers, vomiting, hallucination, and seizures, all due to a sudden withdrawal of alcohol, which means it's very important to properly rehabilitate people who are alcoholics, because without the alcohol, they can experience these horrendous withdrawal symptoms. So it requires medicinal input in order to reduce that alcohol intake safely. Then finally, you've got psychostimulants such as MDMA or ecstasy, which creates euphoria and mild hallucinations by serotonin 2 receptor reuptake inhibitors. It, as an adverse effects, can cause acute hypothermia, which can result in hospitalization, dizziness, coma, and heart failure. Lovely. So the treatments for alcohol addiction are the pharmacological ones that are quite useful to know about. So we're kind of going to go through them by what they would do and why that would help. So we want to alleviate those withdrawal symptoms. So we use methadone for opiates, which affects the mu receptors directly, but doesn't give the same high as other opiates, which means that people don't go into the same withdrawal, but they don't have the high that reinforces that opiate taking. Then long-term substitution, which will have like less harmful effects. So you use nicotine patches to still give that dose of nicotine without all the adverse effects of smoking. So while it doesn't completely cure the problem, it's going to put off the worst action that could be taken. Then you've got a blocking response. So in the case of nicotine and cocaine, you can have a vaccine that's going to where the antibodies bind to the drug as you take it, and therefore it can't have an effect, which means you then aren't going to take it because you're not going to get any of those the fun effects of taking them and those stimulants effects. So then you've got aversive therapies like disulfiram for alcohol intake, which means that when you take the alcohol, you actually have a horrible feeling and you feel really sick and you vomit before the alcohol even has a chance to impact your brain, which means that then you're going to be put off taking it. And it's that idea of the learning again. But here, where you are learning that the alcohol is associated with an adverse event, so you learn to not take the alcohol instead. And then you can also have things that reduce use, such as naltrexone, to reduce ethanol use, because it can kind of be used as a replacement with less harmful effects. Then we also have our behavioural treatments. So there's cognitive behavioural therapy again, which aims to change your thinking around the substance abuse and target often the cause of the initial substance abuse, because often this is comorbid with things like depression and anxiety. Oh, sorry, can you all see that now? That's not good. Then, so you've got your self-help groups, so things like Alcoholics Anonymous, and residence-based care, which is rehab, contingency management. So these are programs that you use so that you are rewarded for drug-free behaviour. So if you are addicted to heroin or something, then we will test you for heroin. If you haven't taken heroin, you get vouchers, which is surprisingly effective for rewarding people for their drug-free periods. And then you've got deep brain stimulation. So this is under a syllabus, which is a bit weird because it's not actually used really yet, but it's an area that's up and coming. So they target the nucleus accumbens, like we were discussing with the dopamine pathway. And activating the nucleus accumbens can prevent people from being addicted to drugs, according to some research, but it's very experimental at the moment. It's not something that's actually done. Right, so that takes us to the end. Any questions?